I'll be presenting a case today titled, "It is Just an Allergy, a Case Report of IgA Nephropathy with Severe Activity and Minimal Chronicity in the Setting of Raw Shellfish Consumption." The relevance of this case is that it presents a common but vague presentation of a progressive and severe disease, as we will see. So starting with the case presentation, a 55-year-old male presented to the emergency room due to a rash and periorbital swelling 6 hours after shellfish ingestion, followed by vomiting dark urine that presented 24 hours later. He had no history of food allergies, no recent symptomatic viral or bacterial illness, and no history of NSAID use or any other nephrotoxic medication. On physical exam, the rash was macular multiform, erythematous, palpable, and non-blanchable, distributed on upper and lower extremities, torso, face, and neck. We can see on the imaging, the figure 1 shows the rash on the right mid-axillary line, and figure 2 shows the rash on the left supraclavicular fossa. Labs on presentation showed a serum creatinine elevated at 2.21, urinalysis reported red-colored urine with large amounts of blood, glucose, and protein, with a repeat urinalysis that was unchanged. Hemoglobin A1C was 5.1, RPR, HIV, hepatitis B and C were non-reactive. Other pertinent labs showed ANA that was positive with an elevated titer at 1/640, ASO below 50, and C3 that was slightly reduced, and C4 that was normal. At this point, renal imaging was pursued with an ultrasound showing no nephrolithiasis or hydronephrosis. The patient was started on steroid therapy with improved serum creatinine, however, with a persistent skin rash. A 24-hour urine protein that was collected showed significant proteinuria at 10,564 milligrams. So at this point, there was concern for glomerular disease, the reason why a renal biopsy was recommended. The histopathology for the renal biopsy resulted in diffuse mesangial and focal endocapillary proliferative glomerulonephritis with focal necrotizing features and crescents consistent with IgA nephropathy of severe activity and minimal chronicity, tubular atrophy and interstitial fibrosis, mild with patchy tubular degenerative changes, and moderate atherosclerosis. The Oxford classification for this histopathology was M1 E1S1T0C2, which indicated increased risk of renal functional deterioration and increased risk of poor outcome even with immunosuppression. The images that we can see are the immunofluorescence and the fibrinoid necrosis. So for the discussion, IgA nephropathy is the most common cause of primary glomerulonephritis in developed countries, with infection being the most studied trigger. Studies, however, have shown that some food allergens that are highly allergenic may participate in the pathogenesis and progression of IgA nephropathy due to intestinal permeability and mucosal dysregulation. Some associated conditions are chronic liver disease, HIV, lupus, staph-associated post-infectious glomerulonephritis, and the diagnosis should be suspected in patients with gross hematuria or microscopic hematuria with or without proteinuria. So the diagnosis in this case was established as well with the kidney biopsy, and there's no specific laboratory finding that can diagnose IgA nephropathy. So this is a case of a common vague presentation of a progressive and severe disease. It can be underdiagnosed or misdiagnosed as an allergic reaction due to a common food allergen being involved, the classic periodic rash, the acute onset and partial resolution with steroids. And in fact, the prevalence of subclinical IgA nephropathy may be as high as 16% of the general population due to the vague symptoms. There's no cure for IgA nephropathy, but many treatments to slow the progression and chronic inflammation, and this can improve the quality of life and prevent severe complications that can lead to end-stage renal disease and eventually require hemodialysis. So the prompt diagnosis may actually change the course of a patient's life. So in conclusion, environmental factors such as food allergens should be considered strong triggers for immune-mediated glomerulonephritis, such as IgA nephropathy. Although association does not mean causation, the fact that the patient's IgA nephropathy was of severe activity and minimal chronicity brings light to the topic of whether the skin and renal manifestations were a response to the exposure of such allergen. So far more than thinking of this as just an allergy, diagnosing this condition correctly can give a patient better quality of life with prompt treatment and slower the progression towards end-stage renal disease that will eventually require hemodialysis and with a significant impact on the patient's well-being. Thank you.